Dr. Kumar. Hi, Dr. Nadeem.
Very clearly, sir.
Okay, please. Okay, sir. Please let me know when to start.
Yeah, I'll let you know.
Sure. Sir, good evening. Akul sir, good evening.
How are you, DIPANJAN?
Should we start? Are you ready?
All good, sir. All good. All good. Yes, sir. We can start.
Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 14B, which is Hematology General and Fundamental. We are streaming live from Jupiter Hospital, Thane, Mumbai, via Kolkata. A very interesting topic today, which is clinical evaluation of patients with hematological disorders. And a very, very qualified, very eminent person who has all the knowledge of pathology as well as clinical hematology to speak on this topic. We have none other than Dr. DIPANJAN HALDAR, who is an MBBS from JIPMER, Puducherry, MD from PGI, Chandigarh, DM Clinical Hematology from Institute of Hematology and Transfusion Medicine, Medical College, Kolkata, Fellowship in Leukaemia and Bone Marrow Transplantation from Vancouver, Canada. Presently is the Consultant Clinical Hematology and Hematology and Bone Marrow Transplantation at the famous Jupiter Hospital, Thane. He's also been the ex-visiting physician at FHCRC, Washington, USA. He's a gold medal in MD, a gold medal in DM, with areas of interest in bone marrow transplantation, blood cancers, thalassemia, refractory anemias, multiple research projects like the evaluation of endocrine function in hemoglobin E beta thalassemia patient with special reference to assessment of growth and puberty, detection of human papilloma virus, Epstein-Barr virus, and cytomegalovirus in lung carcinomas, nutrition and drug interaction in elderly male with benign prostatic hypertrophy and coexistent hypertension and or COPD. With this, before I ask Dr. Haldar to take over, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Haldar, sir, please share your screen and let us start.
Thank you, sir, for your kind introduction. I'm just sharing my screen.
Yes, please. Yeah, we can see your screen. Just make it full screen, please.
Yeah.
Yeah, please
So it's full
press
screen.
that
Is it
hide.
visible now?
Yeah, it's visible. Just press that hide thing. Just hide.
Yeah.
Perfectly fine. So please
Yeah.
start.
Okay.
Absolutely fine.
I'd like to thank you, Dr. Nadeem, for the opportunity. The topic that has been given to me today is clinical evaluation of patients of hematological disorders. So, just a brief introduction. What is hematology? Hematology, as we all know, is study of blood in health and disease, and it includes problem with red blood cells, white blood cells, platelet, blood vessels, bone marrow, lymph nodes, spleen, and the proteins involved in bleeding and clotting. Now, what do we understand by hematological disorders? So, broadly, all the hematological disorders, if I am to summarize, can be classified into broad categorization of three, that is anemia, bleeding disorders, and blood clots. The blood cancers present in one of the following manifestations, that is, they can be present with anemia, they can present with bleeding disorders. So, I'll be going about case-based approach to clinical evaluation of each of these disorders. My main focus will be on anemia, since that is the major chunk of the cases of hematological disorders that we will see. So, what we mean by clinical evaluation? So, whenever I am expected to clinically evaluate a patient, it means physical examination, investigations, and then treatment. So, what is different in hematology? So in hematology, in addition to the above things, so the clinical evaluation often actually starts with a CBC report. So 99% times, whenever a patient is referred to us for a clinical evaluation, for diagnosis, for treatment, invariably the patient does have a CBC report, and our starting point is often a CBC report. We look at the report, and then we go ahead and do a focused history, focused examination, direct or further investigations, and proceed with the treatment. So as I was mentioning, so I'll be covering this based on a case-based approach, so that it is interesting and most of you can stay focused rather than doing a theoretical discussion on history taking and physical examination of anemia. So let me start with my cases. So anemia, as we all know, can present with symptoms of weakness, shortness of breath, dizziness, headache, cold hands or feet, pale skin, and chest pain. And so there are some of the things to be looked on physical examination. So presence of pallor, presence of. So hemoglobin, as we all know, is form of alpha chain and beta chain, and then there is the heme group consisting of the porphyrin ring and with an iron atom in the center. It's just a brief background. So now when we see a patient of anemia, what is the first test to be considered? The first test generally to be done is the reticulocyte count. What is reticulocyte? Reticulocyte basically is RBC2B or apprentice RBCs. They contain fragments of nuclear material, the RNA strands which stain blue, and then normally it is less than 2%. So this I believe all of us are familiar with. So this is our microscope. So in addition, there is something called as reticulocyte production index. What is reticulocyte production index? So this basically corrects for the degree of anemia and adjusts for the increased survival of the reticulocytes in severe anemia. So for example, if the reticulocyte count is 9% and hemoglobin is 7.5 gram percent with a hematocrit of 25, the first step is we correct for the anemia, that is reticulocyte count into the observed hemoglobin by actual hemoglobin. So this brings to 4.5%. And then we correct for the increased lifespan. For example, with the hematocrit of 25, the peripheral blood reticulocyte count has got a correction factor of 2.0. So then we divide this 4.5 divided by 2. So this gives us a reticulocyte production index of 2.25. So why is this important? This is important because when there is decreased production or hypoproliferative, we get a reticulocyte production index less than 2. In patients of hemolytic, we get a reticulocyte production index of more than 2. So this was the first step about evaluating a patient of anemia. That is, we go ahead and look into the reticulocyte index. Second step is basically go ahead and look into the MCV or the mean corpuscular volume. So this classification I'm pretty sure you all are familiar with. We have got based on the MCV anemias which are microcytic, normocytic and macrocytic. So microcytic, what are the common causes? We have got iron deficiency anemia, hemoglobinopathies and sideroblastic anemias. In normocytic anemia, it is mostly the anemia of chronic disease. It could be early iron deficiency in which the MCV is not yet microcytic. It could be certain hemoglobinopathies I will be showing in the cases. Or it could be primary bone marrow disorders or combined deficiency secondary to both iron and B12 deficiency. Or it could be increased destruction, for example, secondary to acute hemolysis in which the MCV will be normocytic. Macrocytic anemias, so the common causes megaloblastic anemia secondary to B12 or folate deficiency, presence of liver disease or alcohol, metabolic disorders, marrow disorders and increased destruction. So could lead to macrocytic anemias as well. So this is the common cause of the second step to be evaluated based on the MCV. The third step to be looked into is red cell distribution width. So what is RDW? So it is basically electronic measurement in RBC size, and this is how it is calculated. We have got RDWC SD and RDWCV. So, but in general, it indicates the variation in the RBC size. And so, based on the RDW and MCV, we have got. So we have already seen what are the causes of microcytic anemia. So now this can be further classified into microcytic anemia with normal RDW versus microcytic anemia with high RDW. So for example, in iron deficiency in thalassemia major, generally the RDW is on the red cell distribution width is high. On the other hand, in microcytic but normal RDW, for example, thalassemia trait or anemia of chronic disease, generally the red cell distribution width is normal. What about normocytic anemia? So again, similarly, we have got causes of normocytic anemia with normal RDW and causes of normocytic anemia with high RDW. For example, early iron deficiency, multiple deficiency, that is both because of B12 and full iron deficiency, and hemolytic anemias. Thirdly, we have got macrocytic anemia with normal RDW and macrocytic anemia with high RDW. So important here to emphasize that megaloblastic anemia, because of B12 deficiency, if we get macrocytic anemia, in general, the other end in patients of MDS or aplastic anemia, although there is macrocytic anemia, in general the red cell distribution width is more or less normal. So this was the third step, and then comes the fourth step. So the fourth step is basically again the evaluation of peripheral smear. So we look into number of factors. For example, all the RBCs are of same size, whether they're in abnormal shape, for example, discoid shape, sickle shape. What is the color or hemoglobin content saturation? Are all RBC of same color or multiple, indicating polychromasia? Are there any RBC inclusions? Are there any hemoparasites normal in number and differential count, or whether there are any presence of any abnormal cells? So this was about 4 steps in evaluation of anemia, and with this, my further talk will be in a case-based format. So I'll be starting with cases of microcytic anemia. So just to recapitulate, as we all know, these are the most common causes of microcytic anemia. We have got iron deficiency, thalassemias, chronic infection, hemoglobinopathies, and sideroblastic anemia. So starting with the first case, this is a 24-year-old gentleman who has presented with glandular swellings for short duration, 1 week duration. On physical examination, this patient did have generalized lymphadenopathy and mild splenomegaly. Okay, so this was seen by a general practitioner outside, and was referred to me as very acute leukemia by lymphoma because of the short duration of lymphadenopathy, and this is what the CBC report showed. So there is presence of anemia, hemoglobin of 11.9. In addition, we see that the RBC is quite microcytic, that is MCV of just 52. The RDW is mildly raised, 19.2. WBC count is normal, platelet count is normal. There is relative lymphocytosis, so the lymphocytes are 60% as opposed to the neutrophils of 36%. Okay, but there are no atypical cells seen. So this is to summarize the findings here. There is microcytic hypochromic anemia, and I say relative erythrocytosis. Why relative erythrocytosis? Because we see that the hemoglobin is less, 11.9. On the other hand, the RBC count, the red blood cell count is increased, that is 6.78. Therefore, that is why relative erythrocytosis. There is lymphocytosis, as I mentioned. The total leukocyte, platelet count, and reticulocyte count is normal, and the peripheral smear did not show any atypical cells. A liver function test was also done, and this showed presence of elevated liver enzymes. SGOT and SGPT both were elevated. The total bilirubin, however, was normal. The creatinine was normal, and LDH was mildly elevated, 322 against an upper limit normal of 225, so about 1.5 times raised. So next investigation to be done. So this is a young gentleman where I have already summarized the peripheral blood findings. There are no atypical cells. And so this was basically a case of infectious mononucleosis. We did EBV, IgM, antibody to viral capsid antigen, and this picked up, this was strongly positive, so this was basically a case of infectious mononucleosis. Now, what about the anemia? So I had shown you that this patient was having relative erythrocytosis, severe microcytic hypochromic picture. So we did a hemoglobin HPLC, and that picked up a beta thalassemia trait. So this was basically beta thalassemia trait with infectious mononucleosis and not a case of any acute leukemia or something. Now, I'd like to emphasize to you what is thalassemia minor. So I'm sure many of you might be familiar with it. So thalassemia minor is the same as the carrier state for thalassemia, and people who are carriers have just one thalassemia gene are said to be having thalassemia minor, and they're essentially normal. That is, most of them don't have any carrier of the disease. Now, but really does not mean much to the patient or the carrier as such. These are some of the famous personalities who are carrier for thalassemia and who are leading more normal life than you and me. But why it is important to recognize? It is important to recognize thalassemia minor because so if both the parents are carrier, then there is 25% probability that the child might be having thalassemia major. So it is very important that whenever we are seeing a CBC report or we have anemia, we pick up thalassemia minor, or we at least suspect it based on the CBC report, and we get the test done. So often the patient will be referred for something unrelated. For example, this patient was referred for generalized lymphadenopathy, and this patient was young patient, 24 years of marriageable age, and so we picked up thalassemia minor incidentally, and we could advise genetic counseling of the would-be spouse. So that is why it is very important to pick up thalassemia carrier. And this is quite prevalent. So even in the general population, it is 4% prevalent, and up to 10% in certain communities. For example, Sindhi communities in certain parts of Bengal, the prevalence is quite high, up to 10%, and therefore it is quite important to pick up thalassemia carrier. And this can be just picked up by careful scrutiny of the CBC report. So, and this is what I was mentioning. So, if the spouse is also thalassemia carrier, there is 25% chance that the children could be having thalassemia major, and this can be totally prevented. So with this, I move on to my second case of microcytic hypochromic anemia. So again, a 24-year-old patient presented with pallor, icterus, and moderate splenomegaly. Okay, so this patient is having a hemoglobin of 8.6, WBC count of 10,100, platelet count is normal, 210,000, differential count is again normal, 74% neutrophil. Having a microcytic picture, the MCV is just 66. The red blood cell count that we see, if it is not as low as the, not proportionally reduced to the hemoglobin level, so that is hemoglobin 8.6, the red blood cell count is still 3.5. So summarizing the findings again here, microcytic hypochromic anemia, relative erythrocytosis, red cell distribution which is just mildly raised, 16.6 against a normal of 14, and normal TLC, differential count, and platelet count. Okay. So now how to proceed in this case? So as I mentioned, this patient had presented with moderate splenomegaly. So that sonography was done, and these are the ultrasound findings. This patient is having mild hepatomegaly with evidence of chronic liver disease. The gallbladder is normal. There is gross splenomegaly on the sonography, and there is perisplenic varices are also noted, but there is no evidence of any portal venous thrombosis. So since there was evidence of chronic liver disease on the sonography, we got a liver function test done, and the liver function test actually showed increased indirect bilirubin. Okay, so total bilirubin of 3.8, indirect bilirubin is 2.5, and direct of 1.3. The liver enzymes are actually normal. So evaluation for chronic liver disease, hepatitis B surface antigen was done, which was present, and so was the hepatitis B virus DNA quantitative PCR. On retrospective history taking, he did admit to receive 1 unit RBC for undiagnosed anemia 10 years back. For evaluation of anemia, iron profile was done, which was normal. Vitamin B12 was also normal. So we are still hunting for the cause of anemia. Microcytic hypochromic anemia. So therefore, once the iron profile was normal, hemoglobin HPLC was done to exclude beta thalassemia trait, but hemoglobin HPLC was also normal. There was no evidence of beta thalassemia or hemoglobinopathy. Reticulocyte count was raised, that is 15%. So here are the summary of the findings that we have got. We have got a young male, 24-year-old male with pallor, icterus, moderate splenomegaly, increased indirect hyperbilirubinemia, presence of microcytic hypochromic anemia. There is relative erythrocytosis, mildly elevated red cell distribution with normal B12 and iron, normal hemoglobin HPLC, and relatively high reticulocyte count. Okay, so possibly there is some degree of hemolysis going on, but what is the cause? And in the background of a microcytic hypochromic anemia. So then, in view of hemolysis, direct Coombs test was done, which was negative. Haptoglobulin was also done, which was normal. So thereby indicating that possibly the hemolysis was extravascular in nature. So what is the next investigation to be done now? So if you remember in the beginning of the lecture, I showed that hemoglobin has got two chains, alpha and beta chains. So we have to remember that very commonly we do exclude beta tetrate. But this patient actually, we did alpha thalassemia by gap PCR, and this did pick up alpha 3.7 deletion in heterozygous form. So this was actually a patient of heterozygous alpha thalassemia, and that who was actively hemolyzing, and this accounted for this patient's anemia and splenomegaly. So now moving on to the second part of evaluation of the second part types of anemia, that is normocytic anemia. Okay, so we have covered microcytic anemia. I have shown you two cases. One is basically of beta thalassemia trait, and second of alpha thalassemia trait. Now moving on to the second part, that is normocytic anemia. Recapitulate before we go into the cases. So normocytic anemia, as I had already mentioned, it could be because of anemia of chronic disease, it could be early iron deficiency anemia, it could be hemoglobinopathies, primary bone marrow disorders, combined both iron as well as B12 deficiency, and increased destruction, so because of autoimmune hemolysis. So moving on to the third case. So this is basically a 60-year-old female patient who is a known case of diabetes and hypertension. She complained of chest pain for which she was taking NSAIDs, and she presented to me because of anemia. So this is a CBC report. We see that her hemoglobin is 8.8, WBC count is slightly reduced, 3040, platelet count is normal, 1,94,000. The differential count pretty okay, so neutrophils of 47%, mildly elevated lymphocyte count of 47%. The reticulocyte count is normal, 1.4%. So I've got an elderly patient, diabetic hypertensive, who is having chest pain and who is having this kind of normocytic normochromic anemia. The renal function test was done, which was absolutely normal. So creatinine is normal, electrolytes, uric acid is normal. Iron profile was done, which was again more or less okay, just transparent saturation slightly borderline. Vitamin B12 was done, which was also normal, 646. The viral marker, okay. So now what is to be done? So this is an elderly lady, 60-year-old, who has got normocytic normochromic anemia, normal reticulocyte count. We have excluded nutritional deficiencies. So what is the next step? So we have to remember the next step in, multiple myeloma can very well present with normocytic normochromic anemia, and we should get protein electrophoresis routinely in such cases. So this patient also serum protein electrophoresis was done, which showed a big M band of 6.55 gram% as shown over here. And this was, so the kappa lambda ratio was also significantly deranged, and beta 2 microglobulin was raised. So subsequently, a bone marrow was done, which showed hypercellular marrow with 25% plasma cell and plasma cell dysplasia consistent with multiple myeloma. So this was basically a case of normocytic normochromic anemia, which actually turned out to be multiple myeloma. So moving on to the next. So another patient, 39-year-old male patient, who was apparently asymptomatic until recently, but who presented with acute abdominal pain when he had gone for vacationing in Ladakh. Okay. So he was said to me because his hemoglobin was low, so hemoglobin of 11.4, WBC count slightly raised, 16,620, but differential count is normal with neutrophil percentage of 75%, and we see that the platelet count is also normal of 2,65,000. So MCV is normal, 83, MCHC is also normal. So basically, young male who was apparently asymptomatic, normocytic normochromic anemia, and reticulocyte count is also normal of 2%. Patient will most likely not have any problem in the future. But it is important to recognize it, especially premaritally, for genetic counseling, because if both the parents are carrier, then there is again 25% possibility of the child having a homozygous sickle cell disease. So moving on to my fifth case. So this patient was actually referred to me for evaluation of indirect hyperbilirubinemia. So I'll come to the CBC report in my next slide. But young male, 21-year-old male patient who was detected to be having indirect hyperbilirubinemia, right upper quadrant pain, mild splenomegaly, and similar family history was present. So you see that total bilirubin is quite high, 8.4, okay, of which indirect bilirubin is significantly raised, 7.5. So almost 90% is indirect bilirubin. Creatinine is normal, liver enzymes are normal. So now coming to the CBC report. So I've shown you that there is indirect hyperbilirubinemia, but fortunately the CBC report is showing a normal hemoglobin. Okay, so the hemoglobin is normal, 14.2. The WBC count is slightly raised with more or less normal differential count. The platelet count is also normal, 3,20,000. The MCV is normal, 85. MCH is normal, 30.7. However, MCHC is slightly raised, that is 36.0. So any clue how to proceed now? So we did a reticulocyte count. Reticulocyte count is significantly raised, 5.8%. So for a hemoglobin of 14.2, reticulocyte count of 5.8% is definitely. And LDH is also slightly raised, that is about 1.5 times raised. So LDH was 390 against an upper normal limit of 225. So now again to summarize the finding, we have got a young male, 21-year-old male patient, icterus, family history of jaundice is there, patient has mild splenomegaly, indirect hyperbilirubinemia, increased MCHD, relatively high reticulocyte count, and raised LDH. So what are the possibilities of increased MCHC? So it could be artifactual. When we remix the EDTA tube, if the MCHC corrects, report corrected results. It could be secondary to presence of cold agglutinin. So how to rule this out? By incubation at 37 weeks, report corrected results and comment on possible cold agglutinin. And it could be because of presence of spherocytosis, that is, for example, hereditary spherocytosis. So this patient actually on the peripheral smear there is spherocytes present, and we got a osmotic fragility test done, and we see that the osmotic fragility was increased, and this was basically a case of hereditary spherocytosis, which was further confirmed. So with this, I move on to the third part of evaluation of anemia, that is evaluation of macrocytic anemia. So just to recapitulate again, what are the causes of macrocytic anemia? So we have got megaloblastic anemia secondary to B12 folate deficiency. We have got anemia secondary to liver disease, alcohol. We have got anemia secondary to metabolic disorders, marrow disorders, and increased destruction. So these are the common causes of macrocytic anemia. So now moving on to the next case, we have got a 65-year-old lady with hemoglobin of 5.3, low WBC count 2900, low platelet count 81,000. The MCV is quite raised, okay, so 114. So quite high MCV. So we see that differential count, there's slight lymphocytosis of 55%, and the reticulocyte count is of just 2%. So to summarize, macrocytic anemia, elevated red cell distribution weight. So the RDW here is quite high, 24.1. Okay, and the low reticulocyte count, low TLC and platelet count. So what could be the causes? So we know that if you remember, I have shown you in the initial slides. So macrocytic anemia, increased red cell distribution weight. One of the most common causes that we have to suspect is B12 deficiency. So this patient we got is quite low, 69 only. So this is basically a patient of B12 deficiency presenting with pancytopenia and macrocytic anemia. So moving on to the next case. So a 44-year-old male with pallor and bleeding. So again we see this patient is also presented with pancytopenia. So hemoglobin of 8. The MCV is quite macrocytic again. So it is MCV is 115. RDW as opposed to the previous case, it is more or less normal, 14.2. Okay. The WBC count is quite low, that is 0.3, and platelet count also quite low, 16,000. And we see in the WBC it is 76%, which is lymphocyte, and only 11% of neutrophils. So young male, macrocytic anemia with pancytopenia, and so what we call as pancytopenia with uniform macrocytosis. So whenever we have got pancytopenia with uniform macrocytosis, we have to remember that the possibility of aplastic anemia or myelodysplastic syndrome is more likely than nutritional megaloblastosis. and especially if the RDW is in normal. And another clue is basically in this patient the absolute neutrophil count was quite low. So absolute neutrophil count less than 200 is uncommon in nutritional megaloblastosis and other causes of macrocytosis, for example, liver disease or hypothyroidism. So in such cases, we have to suspect an underlying bone marrow failure because of either aplastic anemia or myelodysplastic syndrome. So this case, aplastic syndrome, which was confirmed on further bone marrow evaluation. So moving on to my third case of macrocytic anemia. So this is a 62-year-old lady with anemia. So you see this patient has presented with hemoglobin of 4.9, the WBC count is slightly raised, 20,000, and platelet count is again slightly raised of 4,06,000. The MCVC is abnormally high, 130, MCSC is also abnormally high, 87 and 67. In addition, we see that the RBC histogram is not touching the baseline, okay? And the red blood cell count is significantly low, so 0.56, that is abnormally low. And in addition, another finding that we see is the hemoglobin and hematocrit check. So, so roughly the rule of thumb is that it is generally 3 times the hemoglobin level. For example, if the patient is having hemoglobin of 15, the hematocrit roughly is about 45%. So that is the rule of thumb. But in this patient, we are seeing that the hemoglobin is 4.9, but hematocrit is only 7.3. To summarize the findings over here, we have got anemia, macrocytosis, abnormally high MCH, MCSC. So this MCH and MCSC, whenever it is so high, as I was showing in my some slides back, that so one of the causes of abnormal MCSC is cold agglutinin. Okay, so that we have to suspect, especially if there is spuriously low RBC count, as was in this case, and if the hemoglobin and hematocrit check failed, that is hematocrit is not 3 times the hemoglobin, and RBC histogram is not touching the line. So this was definitely confirmed on cold agglutinin, and this is basically a case of cold agglutinin disease. So RBC agglutination possibly secondary to the cold agglutinin disease. So moving on to next case, another patient of anemia. So this is an 80-year-old female who has presented with severe anemia of hemoglobin 5.9. WBC count is slightly raised, 11,510. Platelet count is normal, 3,56,000. And MCV is quite high again, 130 with high MCH and normal MCSC. So here we did the reticulocyte count, which was 1%. Vitamin B12, folate acid, folic acid, liver function test, thyroid, all these were normal. And in addition, the differential count here showed increased lymphocytes, so 70% were lymphocyte. So in such a situation, we have to remember that basically, in addition to B12 deficiency, in addition to autoimmune hemolytic anemias, in addition, we have to remember that bone marrow failures or hematological malignancies could be one of the causes of increased macrocytosis, as was in this case. So this patient, actually we did bone marrow test, and the flow cytometry confirmed the presence of T cell LGL, that is large granular lymphocytic leukemia, and so that was confirmed by flow cytometry report. So in the evaluation of hematological disorders, I have covered about anemia. So I touched upon how to evaluate a microcytic anemia, macrocytic anemia, normocytic anemia, and so with this I'll now move on to the evaluation of bleeding disorders. So this is in general the scheme of the flowchart scheme that we should follow for evaluation of patients of bleeding disorders. So these are the screening tests that we do whenever a patient presents with bleeding. That is, we get a CBC, evaluation of blood smear, PT, PTT, bleeding time, or platelet function assay. Okay. So we proceed further based on, so if the whatever is coming out abnormal from this. So if PT or PTT is abnormal, so only PTT is prolonged, we generally go ahead in the evaluation in terms of hemophilia, that is we go ahead and check for factor 8, factor 9, factor 11. Only PT is prolonged, so we go ahead and check factor 7 assay. PT, PTT both prolonged, we go ahead and check for factor 5, factor 10, prothrombin or fibrinogen. Or it could be just, so if PT, PTT both are abnormal, we often, so it could be because of underlying lupus anticoagulant, for which we have to do a mixing study and to confirm the presence of inhibitors. So in addition, we have to remember that to evaluate for von Willebrand disease, so there has the certain test to be done for von Willebrand disease. There is presence of the testing for von Willebrand factor antigen, ristocytin cofactor assay for von Willebrand factor ristocytin induced platelet aggregation. So if you are strongly suspecting von Willebrand disease, there are certain tests to be done for confirmation of von Willebrand disease. So this was about coagulation. Now what about platelets? So the platelet disorders could be again either congenital or acquired. So we have to go for platelet count. We have to look at the platelet, review the medications that the patient is taking. So often these patients are on antiplatelet medications, and evaluation for other systemic disorders. So often there could be acquired platelet dysfunction because of underlying other disorders as well. So if all these are normal, say PT, PTT, platelet factor, platelet function, if all these are normal, so then we have to go for evaluation for other rare causes, for example, factor 13 assay, go for rare causes of fibrinolytic disorder, evaluate the patient for connective tissue disorders or presence of vascular abnormalities, or look into the rare possibility of child abuse as well. So this is in general how we proceed with an approach to a patient who has presented to us with bleeding disorder. So present a case. So young patient, young female, presented 29-year-old female with anemia and bleeding, petechial and purpuric spots, no organomegaly, no lymphadenopathy. She did have a history of seizure disorder for which she was on clobazam and levetiracetam. So look at the CBC count. The hemoglobin is low, 7.9. WBC count is normal with more or less normal differential count. But we see that the platelet count is severely reduced with a platelet count of 0. Okay, and this was confirmed in the microscope under the peripheral smear as well. There were hardly any platelets seen. So since this patient was having bicytopenia, that is the hemoglobin as well as platelet was reduced. So we went ahead and did the reticulocyte count, which was not. Vitamin B12 was normal. Ferritin was increased actually 606. The iron parameters were all normal, and direct Coombs test was negative. So what is the next test to be done? So the basic biochemistry panel, creatinine and liver function test were all normal. So next we did a bone marrow test. The bone marrow test actually showed megakaryocytes could not be seen on the bone marrow aspirate, and even on the bone marrow biopsy. So this was a good biopsy measuring 2.0 and 0.3 centimeter, and as we see that the megakaryocytes were virtually absent and one. So this was basically a case of a megakaryocytic thrombocytopenia. But this patient, as we see, presented at 29 years of age. So this was a case of acquired a megakaryocytic thrombocytopenia, which is listed as one of the genetic and under one of the rare diseases. So how to treat such patients? So the treatment is basically immunosuppressive therapy, and we could use either of the agents, so basically steroid, androgen, ATG, cyclophosphamide, cyclosporin, and IVIG as well. So cyclosporin alone or in ATG is said to be effective. And these are the various other agents, for example, rituximab, danazol, azathioprine, romiplastim. So all this has been tried, and myeloablative bone marrow transplant has been tried in patients who are refractory. So what we did for this patient, this patient was financially started this patient on cyclosporin and prednisolone, and after 1 month of cyclosporin and prednisolone, we see that the hemoglobin has improved, and as well as the platelet count has raised from 0 to 3 lakh and 312, that is 3,12,000, and the differential count is normal. So basically this patient had a wonderful response to immunosuppression with cyclosporin and prednisolone. So I've covered about anemia, bleeding disorders, and then the last part of the talk will be about evaluation of blood clots. So for blood clots, basically for us, the hematologist, the main role is to identify the presence of inherited thrombophilia. So often we see that the patients present, with lower limb swelling or pulmonary embolism, the patient could present to cardiologist, a chest physician, or general medicine specialist. So they invariably diagnose the patient, start the patient on blood thinner, and the question most often posed to us is how long should the blood thinners be continued, or whether there is any role of testing for thrombophilias. So I'll be covering this briefly. So when is the patient to be evaluated for thrombophilic testing? So if the thrombophilic state is provoked by strong triggers, for example, if the patient is giving clear-cut history of fracture of lower limb followed by prolonged immobilization, so then there is no role of thrombophilia testing. Okay. So if it is provoked by strong triggers, then there is no role for thrombophilia testing. It is provoked by weak triggers, especially in a young patient with strong family history or female patient during age group. So then we should go ahead with thrombophilia testing, that is testing for factor V Leiden, prothrombin gene mutation, protein C, protein S, antithrombin 3, antiphospholipid antibodies, so on and so forth. Unprovoked, so yes, then generally there is generally role of testing. Unusual site of thrombosis, for example, cerebral venous sinus thrombosis or thrombosis in the splanchnic veins, then there is definitely role for testing for inherited thrombophilias. So basically, apart from those thrombophilias which is triggered by strong triggers, or so that there is no role of thrombophilia testing. But in other patients, especially if they are young patients, or if it is an unprovoked thrombosis, or if there is unusual site thrombosis, so then there is definitely role of thrombophilic testing, especially in unprovoked thrombosis. If the patient is young patient, or if the patient is having strong family history, then there is definitely history of there is definitely role for thrombophilia testing. So with this, again, I would present a case which will cover thrombophilia testing and some things to be remembered during thrombophilia testing. So this is basically young male, 26-year-old male who had presented with severe pain in left lower limb for 3 days. There was no history of trauma or prolonged immobilization. On local examination, the patient has severe tenderness and asymmetric swelling of the left lower limb compared to right. And this patient was actually a known case of deep venous thrombosis of left lower limb and used to get recurrent episodes. So this patient actually got 11 episodes of similar complaints. Okay, so he used to land up in casualty every 15 days, every 1 month, with severe pain and swelling in the left lower limb. And this was even when this patient was on anticoagulation. So just briefly going back, so the Doppler was done in this setting as well, and the Doppler confirmed of bilateral lower limb revealed partial thrombosis of the left external iliac, common femoral and popliteal veins. Okay, so this patient definitely was having thrombosis, and this is despite anticoagulation. So now going back in time, so in November 2014, this patient had got the first episode of thrombosis, and this time thrombophilia workup was done. So what did the thrombophilia workup show? That the lupus anticoagulant protein C, protein S and activated protein C resistant was normal. However, antithrombin 3 was mildly reduced, so 65% against a normal of 83 to 128%, and antithrombin antigen was also slightly reduced. So this patient had actually, so because of this low antithrombin 3 activity and antigen, this patient was labeled as antithrombin 3 deficiency. Okay. So this was the label given to this patient. So now when this patient had come, what was curious to me was because like why, so even though if this patient is having antithrombin 3 deficiency, now this patient is on oral anticoagulants, so why this patient should be getting recurrent thrombosis episodes even on oral anticoagulants. So this brings us to a very important practice guideline. So that is, so this part I have already covered, when to evaluate for hypercoagulable state. So one thing that we have to remember is at the time of acute thrombosis, protein C, protein S, antithrombin 3 may be falsely low due to ongoing thrombosis. So if these tests are normal, then the deficiency is ruled out, but if abnormal, they should be repeated when this patient is asymptomatic and off antithrombotic medications for 2 weeks. So this antithrombin 3 which I showed was abnormal was actually done during the acute episode of thrombosis, and it was slightly low and it was never repeated. So, and this patient was mistakenly labeled as antithrombin 3 deficient patient. So this was definitely not the case, and as we see here, this is from the clinical Washington State Clinical Manual, and we see that if the in acute state, if this protein C, protein S, antithrombin 3 is falsely low, then it needs to be repeated. But unfortunately for this patient, he could never be taken off antithrombotic medications, and this could not be repeated. So if not antithrombin 3 deficiency, then why is this patient having recurrent? So you see that this is this patient's course over the last 2 years. So he was started on dabigatran, he got recurrent thrombosis, he was switched to rivaroxaban, he again got recurrent thrombosis. He was switched to fondaparinux, again the same outcome, he got recurrent thrombosis. And at this point of time, somebody thought that it is enough, and IVC filter, so inferior vena cava filter was placed, external iliac vein was stented, and different permutation and combination tried, but nothing seemed to be worked and seemed to be working, and this patient was kept on getting. So this brings us to the present episode. So this patient was seen in November 2015, and so as I was mentioning, this patient was keeping on severe pain in the left lower limb for 3 days, and on examination there was tenderness and asymmetrical swelling, and this patient was getting recurrent episodes of thrombosis even on anticoagulation. So at this point I saw the patient and I switched this patient over to LMWH, and that is low molecular weight heparin and warfarin, so that I could monitor at least the PTINR and to see if this patient is getting adequately anticoagulated. But again, the question remained, why? So what was the cause of this patient's recurrent thrombosis? So at this point, we got CECT abdomen done, and we see that this is the IVC filter, and this is what was quite interesting. So what we see that the right common iliac artery is overlying the left common iliac vein. Okay, so there is a mechanical compression. The right common iliac artery is overlying the left common iliac vein. So this basically was a case of May-Thurner syndrome, with IBC filter in situ and stent thrombosis syndrome. It is also known as iliac vein syndrome or Cocket syndrome or ileocaval compression syndrome. It is caused by compression of the left common iliac vein by the right common iliac artery. And true prevalence is actually unknown, but it is quite rare. So this is what happens. The right common iliac artery overlies and compresses the left common iliac vein against the lumbar spine, and this actually causes a physical outflow obstruction and subsequent venous stasis. Okay, so because of the physical outflow obstruction and subsequent venous stasis, this patient kept on getting recurrent episodes of thrombosis. So already photograph showing the right common iliac artery, white arrow, and this is going and compressing the left common iliac vein against the lumbar spine, and this is what is causing recurrent. This is what was causing recurrent thrombosis in this patient. So what was the basic pathophysiology? This is by anatomic orientation, as I was mentioning, and this because of the compression there used to be is extensive intimal hypertrophy of the vein resulting from chronic pulsatile force of the right common iliac artery. This condition is definitely rare and is seen in 2 to 4% of the 2 to 5% of the patient with lower extremity venous disorders, mostly present with recurrent thrombosis. So this is virtuous triad basically. So we started with hypercoagulability. So this patient actually was thought to be because getting recurrent thrombotic episode because of antithrombin 3 deficiency, but that was not the case. So this patient actually was having endothelial injury, as I just mentioned, because of stasis. There is intimal endothelial injury to the venous of stasis. There is hemodynamic changes and stasis and turbulent blood flow because of the underlying mechanical compression of the vein by the overlying right common iliac artery. So definitely virtuous triad is coming into play, not the hypercoagulability factor, but the venous stasis and the endothelial injury leading to recurrent thrombosis in this patient. So treatment for this patient, there is no consensus in treatment, but for symptomatic patient, basically venous bypass constructed by autologous veins, retropositioning of the iliac artery, and excision of the venous parts. So basically, venous bypass graft is the most common, and that is what was done for this patient as well. And finally, the patient become asymptomatic. So this was briefly about evaluation for hematological disorders. I just tried to touch upon the evaluation for anemia, bleeding disorders, and blood clots, and I just showed some interesting cases because theoretically it was not possible to cover evaluation of hematological disorders in one session. To summarize, basically I am summarizing here the evaluation of anemia. So if hemoglobin is low, do not start on iron straight away. Ask for CBC, order for reticulocyte count. Try to look into whether the reticulocyte production index is less than 2% or more than 2%. Thoroughly look for blood loss, acute, chronic, or try to figure out is it hypoproliferative, hemolytic, or hemorrhagic anemia based on this reticulocyte production index. If hyperproliferative, look into the MCV and the RDW. Okay. So if microcytic, think about iron deficiency anemia versus others. Go ahead and do the iron test, hemoglobin HPLC for beta thalassemia. If macrocytic, these are the common causes. So go ahead and look into megaloblastic anemia. Could be B12 deficiency, folic acid deficiency, or other causes, that is chronic liver disease, hypothyroid, bone marrow failure, for example, aplastic anemia, MDS, or acute leukemia. If normocytic, think of anemia of chronic anemia of chronic disease, could be chronic liver disease, chronic kidney disease. Multiple myeloma is one of the commonest cause of normocytic normochromic anemia, especially in elderly age group. Hemolytic anemia, as I showed you, cases of sickle cell trait, cases of hereditary spherocytosis. So these all could be causes of normocytic normochromic anemia. If reticulocyte count is increased, then go ahead and do the full hemolytic anemia workup. Go ahead and test for LDH, bilirubin, haptoglobin, direct Coombs test, and then obviously further clinical workup is based on the underlying scenario, that is G6PD deficiency, hereditary spherocytosis, HUS, TTP, alpha thal, and PNH. Obviously, peripheral smear examination of the RBC size, shape will always give us clue to the evaluation of underlying disorder. So with that, I would like to end, and I would be happy to take up questions if there are any. I hope this will be useful to all of you.
Right, thank you so much. It was definitely very useful. It is the clinician's perspective from the pathological viewpoint. Wonderful. There are questions, but before that, let me see if there are anybody wants to ask anything from the Google Meet. If anybody is wanting to ask anything. There is a question by Dr. Nabanita Das from the YouTube. Do you use dimorphic anemia in morphological classification of anemia? It will have quite high RDW as expected. How do you approach those cases? And what's your experience regarding the causes?
Right, right. So if you remember, I showed a table like classification of anemia based on the MCV, that is microcytic, normocytic, macrocytic, and RDW, to look into whether the normal RDW versus high RDW. So yes, dimorphic anemia. So we have to remember that often even with the normocytic anemias, that is MCV is normal, but the RDW is quite high. So there could be many causes: combined iron and B12 deficiency anemias. So these are the common causes. It could be, say, beta thalassemia trait with B12 deficiency. So in such cases, the basically, especially in cases of dual deficiency anemias, the RDW will be quite high, and so that is one of the most common causes.
Right. We have a 1 minute lag between Google Meet and YouTube. We'll just, in the meantime, Dr. Mamata Goa Malik says an excellent lecture, wonderfully done.
Thank you, thank you.
We'll just wait.
So I thought that evaluation of all blood disorders, it is very difficult to cover in one hour session. So just touch upon some interesting cases.
No, you have chosen the right cases, and the way you approached it, initially talking about the basics and then talking about the case-based, it was very wonderful, and the cases were also very interesting. It is very important for everybody to realize that hematological practice is not only microscope.
Right,
and pathologists, don't get a chance to get into the clinical side. So telling them about how to approach that will give them an insight as to how to make the correct diagnosis. Wonderful presentation, done. Excellently done. Very crisp, very nice.
Thank you, sir. Thank you.
Very nicely presented. Right? I think there are no questions, so I think we will close the meet here. Thank you so much, Dr. DIPANJAN, for taking out time.
Thank
we
you,
will
sir.
be very obliged. Will be very obliged if you could share the PDF with us. We have a separate Google Drive where we upload all the PDF of all the lectures, so that students can go through that, and we share the link to all the students. So it will be very nice if you could share the PDF with us. We'll upload that. We will also share the Google this presentation's YouTube recorded version with you as well as with everybody. Thank you so much, sir. God bless you.
It was a pleasure.
Thank you, sir. Take care. Bye bye.
Thank you.
Good night.
Bye. Good night.
Bye. Good night.